Welcome, students! Before we get started, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. All right, today we are unpacking something absolutely fascinating, the MSDRG value chain. We're going to trace the exact journey of how a physician's quick clinical notes are systematically translated into the final reimbursement a hospital actually receives. It's kind of like a giant puzzle made up of clinical data, strict coding rules, and financial formulas. But don't worry, by the end of this explainer, you'll see exactly how all these pieces fit together. So, here's our roadmap for today. We'll be covering 1. The MSDRG payment system, 2. Principal diagnosis and POA, 3. The impact of CCs and MCCs, 4. Clinical documentation integrity, and finally, 5. Claim validation and audits. Let's dive in. Starting with Section 1, the MSDRG payment system, setting the baseline. Okay, to really understand the Inpatient Prospective Payment System, or IPPS, you have to get comfortable with its core framework, which is the MSDRG. That stands for Medicare Severity Diagnosis-Related Group. I want you to think of the MSDRG grouper as this massive, complex logic engine. Think about it. Every single day, hospitals see thousands of wildly different patient cases, right? Amazingly, this system manages to statistically classify almost every possible human medical event into just about 750 distinct payment categories. It's honestly an incredible feat of categorization. The whole goal is to group patients together who are expected to require roughly the same amount of hospital resources. But that brings us to the ultimate question, doesn't it? How exactly are these highly complex, individual medical encounters transformed into a specific financial calculation? Like, how does a patient's unique biological event turn into a neat little line item on a hospital's balance sheet? Well, it all comes down to this core equation. The DRG system groups patients based on two main things: clinical similarity and resource similarity. So if you have patients with similar clinical characteristics, meaning similar diagnoses and procedures, and they consume a similar amount of hospital resources, things like nursing time, imaging, and lab tests, they get bundled into one single payment group. The hospital gets a fixed prospective payment for that group, and that's true whether the patient stays in the bed for 3 days or 5 days. Moving right along to Section 2, Principal Diagnosis and POA, the mechanics. Now, listen, there is a critical distinction here between the primary reason for admission and the principal diagnosis. They are absolutely not always the same thing. Let me give you an example. Say a patient comes into the ER complaining of severe chest pain. That's their primary symptom. It's the reason they walk through the door. But after an EKG and a bunch of blood tests, the doctor determines they're actually having an acute inferior wall myocardial infarction, a specific type of heart attack. That heart attack, that is the principal diagnosis. It's the condition established after study to be chiefly responsible for the admission. If a coder mistakenly just uses chest pain as the principal diagnosis instead of that specific heart attack code, it literally changes the entire major diagnostic category. That leads to massively inaccurate DRG assignment and, you guessed it, severe underpayment for the hospital. And right alongside that diagnosis, coders have to assign a present-on admission, or POA, indicator. A Y means the condition was already there the exact moment the patient was admitted. An N means, no, it wasn't present, it actually developed during the hospital stay. You also have U for insufficient documentation, or W if it's clinically undetermined. But let me tell you, this tiny little letter carries enormous financial weight. The true importance of that POA flag becomes incredibly clear when we start looking at complications. Say a patient is admitted, and a few days later they develop a new condition, like a deep vein thrombosis, a DVT from being in a hospital bed. That DVT gets a POA flag of N. It's officially considered a hospital-acquired condition, or an HAC. Under Medicare's rules, the hospital gets penalized for this, even though a DVT is a major complication that would normally increase the DRG payment. Because it happened on the hospital's watch, the system completely blocks it from bumping the case up to a higher payment tier. Basically, the hospital just has to absorb the extra cost of treating it. All right, Section 3, the impact of CCs and MCCs, the ripple effect. Within almost every MSDRG family, there is this really interesting 3-tier logic system, and it's based entirely on secondary diagnoses. Down at the base level, you have the DRG without CC/MCC, which gives you the lowest payment. Now, if the patient's record documents at least one condition flagged as a CC, a complication or comorbidity, boom, it bumps up to the middle payment tier. But if there is just one diagnosis flagged as an MCC, a major complication or comorbidity, like acute respiratory failure or severe sepsis, it pushes the entire case all the way to the highest payment tier. This represents a really substantial, dramatic increase in the hospital resources expected to be used. Let's actually ground this in some real math to see the impact. Every DRG has a relative weight that acts as a multiplier. Let's say a hospital's base rate is $6,000. If a case groups to a DRG without any complications, they might just get that straight $6,000. But if a major complication is properly documented, it might change that DRG relative weight to, say, 1.3. Suddenly, that same $6,000 base rate is multiplied by 1.3 and the payment jumps to $7,800. That is an $1,800 difference for a single patient stay, and it relies entirely on accurately capturing the true severity of their illness in the clinical notes. Which brings us to Section 4, Clinical Documentation Integrity, the human element. So, expecting doctors to perfectly document every tiny coding nuance while they're actively trying to save lives? Yeah, that's completely unrealistic. That is exactly why hospitals rely on clinical documentation integrity, or CDI teams. These folks walk a very tight rope between two major risks. On one side, you have upcoding. This is when you assign higher-paying codes that the actual clinical evidence just doesn't support. This is a massive compliance risk. It's considered fraud under the False Claims Act, and the penalties are severe. On the flip side, though, you have undercoding. If a physician uses vague language, the coders simply cannot assign those higher severity codes, even if the patient was genuinely incredibly sick. That leads to lost revenue and artificially lowers the hospital's case mix index, which basically makes them look less capable on public quality reports. It's a lose-lose. So CDI acts as the bridge here, performing what I like to call ethical optimization. CDI specialists will actually review patient charts concurrently, meaning while the patient is still in the hospital bed. If they see lab results that clearly point to acute respiratory failure, but the doctor just scribbled shortness of breath in the notes, the CDI specialist steps in. They'll send a non-leading query to the physician, basically just asking them to clarify the diagnosis for the record. They are there to ensure that clinical accuracy directly translates into coding accuracy, which is what ultimately guarantees financial accuracy. Finally, Section 5, Claim Validation and Audits, the final output. So where does all this meticulously gathered data go? The principal diagnosis, the surgical procedures, those POA flags, the discharge status, it all ultimately lives right here on the standard institutional claim form. You might know it as the UB04 or its electronic equivalent, the 837I. As you can see, the form requires specific fields for every single detail we've just talked about. And here's the kicker. If the data in the hospital's electronic health record doesn't map perfectly to these exact fields, the claim is going to be flat out denied by the payer. To prevent those painful denials, hospitals use a pre-submission validation workflow. Before a claim ever even reaches Medicare or a commercial payer, it passes through a clearinghouse. This software runs a syntax validation, catching things like a missing POA flag on a secondary diagnosis, or maybe some mismatched revenue codes. If it flags an error, the claim gets kicked back to the billing and coding team. They fix it in the revenue cycle management system, and then they rerun it until they can confirm it is perfectly clean. But hey, a paid climb isn't the end of the story, not by a long shot. Government bodies like recovery audit contractors, we call them RACs, they routinely perform retrospective audits. And let's be real, they are looking to recoup money. They will heavily scrutinize a patient's chart to ensure that the inpatient stay was truly medically necessary. They'll do strict DRG validation to see if that high-paying major complication was actually supported by the clinical evidence, or if the principal diagnosis was even selected correctly in the first place. If your documentation is weak, they will absolutely demand that money back. Which leaves us with this final, absolutely vital question. Is your hospital's clinical documentation truly capturing the severity of your patient's care? Because as we've seen today, every missing detail isn't just a gap in the clinical story, it's a direct financial and compliance vulnerability. Next time, in part 58 of our masterclass, we are going to dive much deeper into the exact math behind all of this by unpacking the inpatient prospective payment system formula, including base rates, relative weights, and cost outliers. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Thanks so much for learning with us, and I will see you in the next explainer.